Bonjour, and that's about it that I know in French. However, my son, who's 17, he studies French, so I have hope for coming back and having a translator. Yes. Yes. I am an occupational therapist. I was educated in '92 and worked as an occupational therapist with psychosis and eating disorders for about 10 years before my academic career. So I brought that heart into research, and I'm going to talk about it today. So in our research group is called Mental Health, Activity and Participation. And we try to develop but also implement and evaluate psychosocial intervention in Sweden on a national context for people with mental health problems. I'm just going to say that mental health problems we choose as a concept since we do not focus on illness, but we focus on the disability or the problem itself. We also use user involvement, people who have own experience, to inform our research, but also in the decisions of what research to focus on. I'm going to start with a concept from the sociology, and I understand that there are a few social workers here today. So people, occupational therapists, sometimes depart in sociology to understand the occupational arena. So I want to be just and tell you that social deprivation is really about this reduction of culturally, socially activities and occupations. So it's like apartheid from you and the social life in society. So it has to do with social exclusion. And this social exclusion affects many people with mental health problems in particular. So that's my focus today. So social deprivation is very much about the limited access to the social world. When we come to occupational deprivation, which is a common concept in occupational science, it's more to do with the lack or not ability to engage in occupation because of external factors. So occupational deprivation is not a subjective or personal issue. It depends on the outside world. So that's an external cause. So you have, when you become mentally ill, you are deprived from situations that contribute to occupational engagement. Perhaps you cannot access vocational rehabilitation. Perhaps you cannot access workplaces or even have the courage to visit shops, but that's not systematic. But also digital and technological development is also an issue that could be external and could cause occupational deprivation. So this is an echo from what I've just said, that occupational deprivation results from this cultural exclusion, but is also a byproduct of technological advancements, economic models, when a society tries to be as effective as possible and cut down the possibilities for people to get supported work, for example, and also welfare benefits that they cut down welfare benefits, which hinders people to come back and integrate in society. So in Sweden, it's mostly the welfare system and also the workplaces, the regulations there that really cause the deprivation. And of course, our attitudes. I'm going to come back to that later. Oh. So we can conclude that persons with mental health problems are at risk of becoming occupational deprived and having this experience because they are often unemployed, and poor and become marginalized. And also their voice in society becomes limited. So they are at risk of becoming marginalized and deprived. But to remember, when a person, if I would have a psychosis, for example, I would not be deprived immediately. So I think that occupational therapists and social workers need to perform early interventions and work with occupational engagement in an early stage in their situation. So why is this occupational deprivation? I talked about technology, welfare systems, political and economy factors. But I believe that the most contributing psychosocial factor is that of stigma, public stigma. If you recall, sometimes when there are crime committed or sometimes murders, and if there is someone who performed it, who had mental health problems, they all, oh, it's the mental health problems is bad, and also the history of having schizophrenia in the institution. People get a bit scared, they're a bit afraid, and this internalized stigma is also part of the experience that people, users, have as well. So the public attitude is part of the person who's ill as well. So they stigmatize themselves by themselves. So if you get a mental illness, if I have a psychosis, I probably would say that I'm not worth as much as before. I'm not going to be able to work again. And my doctor perhaps says that this is a chronic condition, and you will probably not be able to be the same ever again. So you sort of get informed with this lack of confidence, which is big trouble. So I would say the attitudes that people don't believe that you can recover is the largest issue we have to battle. So how can occupational therapists and social workers turn this trend around? Well, I work with a concept. This is about occupational engagement. And I did, in my PhD studies, time use studies of people with schizophrenia. So I looked at what they were doing in the day, who they met, their experiences, and how the occupational pattern were built. And I could see that it was very diverse. Some people with schizophrenia had jobs and were really integrated in society. And at the beginning of the occupational engagement continuums, there were people who just had their first psychosis perhaps, or had a chronic and occupational deprived situation at the beginning of the occupational engagement continuum. So I noticed that the occupational engagement was very diverse in the same population. So you can have little engagement or you can have a lot engagement. So it has to do with whether you have a balanced rhythm of activity and rest, for example, if you have routines, if you can move around in society. I could see that people who had little engagement also did not move around in society much. They stayed at home, and their activities often peaked around eating and perhaps smoking and things like that. And occupational engagement also involves subjective and objective dimensions. It involves the meaning making as well as the doing. So to be engaged in occupations actually is the foundation for mental and physical health. And if you have ongoing occupational engagement, it also is the foundation for making sense of experience. And as you can see here at the last point, this time use research has contributed to the understanding of how occupational engagement is related to mental health. So here you can see the citation. That's actually my PhD student studied from 10 years ago, but I think that it's nice for you to read about schizophrenia and time use and occupational engagement. So we could see that the occupational engagement process regards the fit between the occupational area to have adequate, good occupations throughout the day, and that environment that supports what you want to do. Perhaps someone in the environment asks you what you would like to do in the day, in a month, and so forth. So you are provided with opportunities. And also that the mind is set in a way so it can absorb and interact with the environment and make sense of it. So that's the very foundation. But for example, if you are not provided with occupational opportunities, you are not perhaps, and you're not able to connect to the outside world, it's difficult to be engaged. I could see in these time use diaries, people were quite disconnected or disengaged. They did not relate to the environment. They were quite inside themselves, so they related to themselves and their voices and so forth. So they did not have the opportunity to relate to the outside world. So this is, there is actually a French assessment model that I've done. It's in Swedish and English, but the Canadian French researchers just translated it into French. You can find it on the web. So that's actually the time use diary that I've used that you can do further reading about, and also how you can assess the occupational engagement and address to what extent a person with mental health problems have engagement. And since it's very basic, the patient client writes down his life, you can also, as an occupational therapist, talk about it, have discussions about life, and talk about what they really feel that they would change or not, and what creates health and what does not. So you really do, as an occupational therapist, you really don't need to assess it, but we need assessment in order to measure occupational therapy in relation to health. So that's why I developed this instrument. So in my PhD, I did some quantitative calculations. So what you see here is that those who had a low level of occupational engagement, this was statistically correlated to having a locus of control. That means that someone else, or the institution, or the mental health ward, or someone had the control over the life situation, not me as an ill person. They had a less sense of coherence, less sense of mastery, more symptoms, worse psychosocial function. They were not that happy about their everyday life. They had a low activity level, worse quality of life, and worse well-being. And people who were more engaged, who were moving around in society more, who were talking to people, and had more choices, or perhaps worked or studied, or were having not long periods of passive, quiet activities, were more satisfied as well. So this connects time use to health and occupational therapy to health. So this is very important with research, I find. So mental health I also want to address, because recently I've focused on mental health, having the occupational therapy with me. Mental health is a state of well-being, of course, where the individual realizes their own potential, what they can do, and how they can cope with normal stresses of life, and that they can find perhaps a work or somewhere to go to be productive, and make contribution to society in the way they want. And I think that we all, occupational therapists and social workers, should promote this hope and recovery and well-being for our citizens. and we should focus on occupational engagement to make them engaged in occupations they enjoy or need. I think in Europe and also in the States, of course, this consumer movement or user movement since 20, 30 years back, people who have own experience of mental health problems have raised their voice and talked about recovery in a sense that's not about clinical recovery, it's about personal recovery. So this is a good foundation for occupational therapists as well, to consider the same with mental health definitions of mental health is that you do not have to be well or get rid of your symptoms. You can still have a good life, although that you have schizophrenia, you hear voices, you can still get a good job, because it is the understanding of how the voices impact on your occupational performance that's important. Perhaps the problems with mental health only occurs in the transportation to the job. Perhaps the problem only occurs when you're alone at home. Perhaps you can work just fine like anyone else. So clinical recovery is about getting better. And it's assessed by the doctors of occupational therapists, by us. But recovery, according to the consumer movement, but also an increasingly policy movement in mental health, is about that only the individual knows how he or she can get better, not the occupational therapist, not the social worker, actually at all. So recovery can be observed through clinical language. Doctors and we often address what we see, what we observe in a clinical setting, but we cannot tell if that person is recovered or will recover. Only the person can, him or herself. According to clinical recovery, very few people recover, but this is not true. As I spoke about before about the schizophrenia, people do recover. I don't have to go through it all. You can read it afterwards as well. So treatment is very important in personal recovery as well, but it goes hand in hand with the goals of the individual. So this is very important. And I'm sure that you already know all this, but it's nice sometimes to have a frame and to understand the distinctions between the two. So personal recovery is described as a process of positive adaptation to illness and disability. And it's linked to a sense of empowerment, that a person gets the occupational opportunities to do what they actually want in life. And sometimes, as an occupational therapist, you want a patient to become all the way good or all the way well, while that individual perhaps only wants to lose some weight, perhaps to get the wedding ring on or something. So we cannot decide what recovery is for a person. We have to ask and really listen. Because remember, the mental health is connected to the well-being of a person, not whether they have recovered in a clinical sense. And I just want to mention that there's a framework called CHIME, and the acronym stands for connectedness, that it's important to be connected to society, and that we provide hope and optimism for the future. And identity, it's very linked, I think, to occupational therapy, about developing work identity, identity in the family, different roles that become quite immediate when you participate in society. And also empowerment is important. So this personal recovery movement is in fact also in research based on experiences that people with mental health problems have. So it's a strong antidote with our expertise and expert roles So OTs can work with this, but need to understand that they can deliver their expertise in accordance to the occupational needs of the individual. So we just have to be more adaptive. In this field, we talk about recovery-oriented services. And it is about being, in occupational therapy, we talk about client-centeredness. Here they say person-centeredness, but it's almost identical, that you depart from the individual needs, of course, and you organize the support around the individual according to how many people they need. In supported employment, in which I work, sometimes a person only needs an occupational therapist in order to go back to work in a good way. But sometimes they need a welfare counselor, sometimes they need to see a CBT counselor, a psychologist. Sometimes they have financial issues and need a social worker and we call them curators, and they need to see the doctors regularly. So a person-centeredness is about organizing care and support according to needs. They do not have to go through the obligatory routes of our welfare services. So this is important, I think. And you have to respect the individual's decision-making. And in just like we do as occupational therapists and in social work, the very key or heart of it all is to build a good relationship with the patient. It does not have to be best friends, but you have to really respect the other person and listen in a mutual, micro-political, equal system. So I listen to you and you listen to me, and let's make decisions together. So sometimes people do not know what they want to do or how they want to proceed in life. And then, of course, you can talk and inspire and provide some hope, of course. You don't have to be dead quiet and everything, but it's really important that they sort of like you, you know, because it's that relationship that's going to bring the rehabilitation forward. So in, how many minutes do I have left? I just want to sort of, sorry? 50 minutes, oh, that's good. So in the word or in research, there, you know, evidence-based practice, that's when they have an idea of an intervention. So try this, for example, assertive community treatment, and you compare this to the ordinary care, for example, and then you test it for a while and you see which one is the best. So these recovery-oriented services here is mostly evidence-based, which means that they have been trialed, like a medicine. Is this medicine good or not? So this is important, I think, for occupational therapists to also do, does this occupational therapy or occupational science intervention, is this better than the other? And can we prove it? Because it's good for policy making as well. Have you heard of assertive community treatments in psychiatry? No? So it's not that tricky, really. It's working with mental health problems in a team, but in the community. So you do not sit in the office or in the ward that much. About 70% of the work time, you're out and about in society, at where people live, where people work, where people educate themselves. So the team includes occupational therapists and a social worker for housing, mostly in this, and substance abuse. They also tackle everyday life. So the thing here is that you move to where the patients live their life. So it's about early intervention. It's about not waiting very long time for becoming very ill and going to acute mental health facilities, but it's actually to address the problems straight away. So this has shown to reduce hospitalization and need of care greatly. So in Holland, there's to make this model cheaper, they've designed a model called flexible ACT. So it's a normal team, but when a person who has mental health problems becomes worse, they put it on a fact board. It's a digital board every morning. So they have these fact patients on the board, and then the team works like an ACT team. You get out and about society, go home to the family perhaps. If you feel bad at work, the employment specialist, occupational therapist goes to the job, solve the issue there. So I think that this is the model for the future very much, that you work in both ways. Peer support. Are you familiar with peer support? Yes, good. So peer support is involving, it's involving people with own experience of mental health problems in the practice. So these ACT teams and these flexible ACT teams, they have, Flexible FACT has 3 peer supporters in every team. So there's 3 persons working in the team who has own experience, because they meet patients at a different level than we are able to do. And in these teams, it's also very good if perhaps me as an occupational therapist, if I have a history of mental health problems, it's good to have both competencies. So both occupational therapy and experiences of mental health problems is very good. So they work as mentors, and they're good for providing hope and for meeting up the person and stop isolations and so forth, and create a picture of that it's possible to recover. So it's much to do about hope and being on that previous journey before. And this slide, in Sweden we work in a quite large project together with the user-consumer organization in peer support. So we do not try to make the randomized controlled trial, we just sort of follow what they're doing and try to cope with that. But there is a manual in English that you can look at, and in the English-speaking countries, the peer support is all around the world, of course. But we're trying now in Sweden to make it happen. So we talked about how the team can organize themselves to meet the mental health problems and occupational engagement needs. But also there is lots of self-management intervention that the individual, him or herself, can do on their own to recover. So there's one called EMR, Illness Management and Recovery. That's also evidence-based. That means that the person gets to manage how they take the medication, they get to recognize early symptoms and learn about the illness and how they should manage it on their own in strategies, but it's taught in a educational mode together with the team member. So wellness, recovery and action planning explores the recovery goals and the and how you make a plan to recover. And I think here that occupational therapy is we should make this kind of self-management thing about everyday life and occupational engagement. We should try to make this, because I think that we could do this very well together with people with experience of having mental health problems. I'm just going to mention these as well. I work with a psychologist from Israel called David Rowe, and he works and he invented together with Janos a thing called narrative enhancement and cognitive training. So it's like a psychoeducative course that you go through together with other people with the same situation, and you work with your self-stigma. You talk about the issues, that you experience. You discuss stigma and what it is and how society relates to it. And you try through these 20 weeks to reconstruct your own story so that you are more prepared to meet the world. So we think that lowering your own self-stigma will actually make it more possible to engage in occupations in the future, because you would not think, I'm bad, I cannot do anything. So I think this is a very important intervention. And sensory modulation you know about as well. So, yes. I worked mainly with supported employment, which is an evidence-based practice. And it's not much to it. I think that many of you already work with supported employment, but perhaps you don't frame it like this. Because the only thing that you have to think about, we work according to these principles, and there are 8 of them. So if you follow these principles, you are doing individual placement and support and supported employment. You have to make sure that you support the work goals of an individual. If a person comes to you and say, I want to be a carpenter, then you have to listen to that, the person-centeredness, and actually go for that as well, to support them in that strive. For example, I had this person who said he wanted to become a pilot. And I said, fine, that sounds very interesting. But I believed as an OT that that wasn't possible, but I didn't say a thing, of course. And we just moved really rapidly into that environment of, airport. And went there, and we talked to people, we talked to pilots, and he said, well, I'm not going to become a pilot, really. It's going to take lots of education. But I really enjoy the environment. I really enjoy being here, seeing people coming and going, and the stewardess are really nice and looking. So he started to work part-time, and he managed the windows, the big windows. So this was his. After maybe 3 or 4 months, going to different places, talking to, he got a job, and he still got a job. So you cannot say it's not possible. Yes. In supported employment, you want to have employment. So you don't enroll people who don't want to work, because it doesn't work, because you really have to listen to their recovery goals. You remember. You go out to the workplace within a month. It doesn't mean that you get a job, but it means that you get connected to the real world really quick. And occupational therapists do an excellent job in pre-vocational settings and training. But sometimes, perhaps, I think, it's better that we do the training and put our knowledge in the workplace context instead. Because if you train a person in vocational activities, social skills, and then take them out of that context into a new setting, you have to train and adapt all over again. You have to compare it to a person in a wheelchair that managed to do all the, learn how to drive and everything, and then you change the physical environment so you can't get in. It's exactly the same. You have to train and support people where they want to be active. So I think the workplace is a very golden opportunity for occupational therapists to work in. And you have to integrate the support with mental health services. You remember I said in the ACT team and flexible team, there's employment specialists and occupational therapists doing support employment in the team. So the mental health is intertwined with the work situation. So when someone starts to feel a bit ill, you can call a doctor straight away. You don't have to get rid of the job and then start from the beginning after 2 years. So it's early intervention all the time. I can also mention the last principle of developing a relationship with employers. Get to know them. They do not think that people with mental health problems are worse workers or anything like that, but they do not know often. They are a bit insecure. What is a mental health problems? Does this affect my productivity as an employer? And then the occupational therapist working with supported employment can talk about the mental health problems, talk about the issues, and be there perhaps the first few weeks, and then be available over time. And so the employers are not the problem here. It's our thinking about people going back to work with mental health problem that is really the problem. And when I started this project, a psychiatrist told me, but Ulrika, if I have one schizophrenia person who wants to work here and one without, why should I employ the person with schizophrenia? And I didn't know what to answer, but I said at the end, because he would do the job better. You know, so it hasn't. We advocate the ability, the resources, and people with mental health problems have plenty of resources. So that's what you match the job. We have people working with car prototypes, engineers. So it's all to do with how we think about things. And it's very effective, this rapid approach to work based on client preferences. Because a person might be able to work in one place and not the other. So it's really important to get the right and good employer that gets to know the person and that you get the support. If you would place the same person in another context, perhaps they would have zero work capacity. So that's where our competency comes in. Yeah, 2 minutes. So we worked on trials for people with psychosis, and we managed, but this is a long trial, it's 1.5 years. We could see after 1.5 years that 46% of people with schizophrenia got a job. Not full-time all the time, but part-time. From 20% to 50% was the most common. They also had internship, they got practice, and they also had studies. And they also felt better. So if we empower people and work towards their recovery goals and use our competencies of occupational engagement and work in the workplaces, we actually make people feel better as well. And we also wanted to know, does supported employment integrated with CBT work as well as IPS for people with psychosis? And we found that 42.4% entered employment. And in this group, it was more like full-time employment, people with depression, because their cognitive skills are a bit better, I must say. Yes, and also they improve their health. And you can see occupational engagement. I do my occupational therapy. I stick in to see if the occupational engagement change. You know, so people with schizophrenia, when we started, as you can see here, I think this is my last thing, for psychosis and the non-vocational outcomes, you could see that before they entered the trial, they did almost nothing, you know. And then someone said, what do you want to do? What would you like to work with? And said, what? Don't I need some training, or social skills training? Or no, you can work directly. Where do you want to work? And they couldn't believe it was like Christmas for them. And so from this occupational deprived situation, to be supported in a person-centered way, to be provided with hope and a means to recovery with a mental health care team, they also increase their time use and occupational engagement. Yes. So take-home message, we need to focus on the occupational engagement and provide support for recovery services. And we need to develop and evaluate interventions, occupational therapists. I think this is very important. And we need to integrate our services in the community, not sit in occupational therapy wards, that much at least. And also work in a broader social and cultural context. And I think that, you know, Frank Kronenberg, Occupational Therapy Without Borders, he's really a pioneer, although, you know, he talked about it 10, 15 years ago. I think this is very much the way to go, to integrate our services in society where people are at. So, thank you.